Hello and welcome to this video looking into overview of hip injuries in runners. So in this video we'll be looking into a general overview. We won't be going through any specific conditions. We'll be covering GTPS and proximal hamstring in a separate talk, but this is just to get us the viewers into the concept of dealing with this sort of injuries in runners. So although the most common injuries are in the knee, the most common injury is generally patellofemoral pain. Hip injuries can be very challenging. They can be very chronic and be very frustrating for the runner. And so it makes sense to be having a good progressive approach and also a systematic way of analyzing hip injuries in this population. So we're going to dive in and see what are the ways which we can make the journey easier for the runner. So first, always good to look into biomechanics and looking into training loads. So there's a lot of misconception that running is bad for the hips and knees and leads with arthritis, and we know the evidence that that's not the case. So this study looked at the loads what takes to the hips. So if you're going to walk for 5 kilometers and if you're going to run for 5 kilometers, the load on the hips is much lesser with running than walking, purely because the per unit distance loads are much lower. So the body is designed for running. It's something which we have done it for thousands of years. And if you look into specifically into the most important muscles for the main contributing factors during running, it's the big three key muscles: glute max, glute med, and iliopsoas. So that makes sense to be working on those big muscles when you are when we are sort of focusing on the rehab. So that's something really important to be aware of, which is integral. So hip, from a joint load of point of view, it's designed to take that. Obviously, if you increase the speed, if you do uphill running, it's going to be much higher. So this is for submaximal running. Now, one of the two key muscles which we sort of go through in the rehab is glute med and glute min. So two important muscles which we sort of we address during the rehab phase. They have got quite interesting roles. So this sort of study from Nunes looked at symptomatic 10 runners. So the reason I picked up this article was it was in the running population, although they didn't have any pain. And as you can see, they sort of all the fibers of glute med, they have a key role during the stance phase. So obviously they have a big emphasis on pelvic stability. So the smaller glute min is less likely to generate the sufficient force for pelvic stability and has a role in hip joint stability. This is highlighted during the swing phase, where anterior glute min shows a burst of activity when the femur is propelled. So this is really important to be aware of, especially when you look into our exercise prescription. As anterior glute min is situated more anteriorly, it's possible this contributes, it also helps in the action of iliopsoas as well. So the glute min works with the iliopsoas in the stability of the femoral head. So so from a femoral head point of view, the stability from glute min, the stability of the pelvis, especially in stance, is glute med. So when a runner comes to your clinic with hip pain, obviously, we have to go through a detailed subjective, and there's a lot which we cover on the assessment module. But what are the key questions? So these questions could be related to any runner with any type of pain, but I'll be picking up a few particular points which will be related to running with hip pain. The most important predictor of future injuries is previous injuries. So we want to make sure we know exactly what sort of injuries they had, especially stress fractures, chronic tendinopathy like GTPS, proximal hamstring, any major fractures like long bone fractures of the femur, because this could have implications of recurrence. And with all runners, we want to know exactly how much are they running, how many miles, how many days, are they doing any cross training, are they doing any gym training, and the total training load and the lifestyle. So those things are really important. And another reason people we see in the clinics with frequent injuries, recent change or recent spike, either in the training or lifestyle. So I want to know if there's been any change in their lifestyle in the last 3 months. Have they increased the volume? Have they increased the speed? Have they changed the surfaces, doing more of hill training? Have they started doing on trail running or ultramarathon? Are they charged doing shoes, gone for a minimalistic shoe or a maximalistic shoe? So this all things can be important because sometimes these are the triggers which leads them to pathology and pain. And 100% of patients who come to me with pain. So I'm more interested in the pain character. Is it mainly during running? Does it get better after training, or is it worse the next day, or they have to stop training because of it's too intense? And the irritability will help me to the rehab. Is, do they get only with the running, or do it's also effective with the ADLs? Do they get night pain? Do they limp? Limping is quite common with intra-articular hip pathology. Can they sit comfortably? Can they drive? All those factors. So if it's just running, then it looks more positive. If it's more ADLs, then I'll be more concerned. Could be other conditions. So it sort of gives me a framework. Now, if a female runner comes to me with hip pain, I'm going to be quite cautious about not missing bone stress injury. So the female runner, we want to make sure that we are aware of the BMI. We know one of the key risk factors is low BMI, especially below 19. Eating habits, weight loss, issues with their bone mineral density, low vitamin D, amenorrhea, low iron levels. All these things are really important for energy levels and for bone health. And when we talk about bone stress injuries, we know the biggest risk factor is previous injury, female sex, and also low BMI, especially below 19. So those are the things, especially from hip injury, you always have that slight suspicion, always in the back of the mind, to make sure that we are not missing. And this is a nice sort of set of 10 questions. I picked up only 5 from that, from University of Wisconsin Running Injury and Running Recovery Index from Nelson et al. In 2019. So we want to know, how much pain do you experience? It could be mild, moderate, severe. It could be from 0 to 10. Is it when you run all the time, or when you run on speed or hills, train? How is the 24 hours? I want to know the latency and the irritability. How is your weekly mileage or running time changed? Are you able to still run the same distances, or is it you have to alter it as well? And speed, do you think you can't do the speed work as much as you did? And most important, do you feel like it's making effect on your lifestyle? It's sort of having that effect. And at a later stage, I will definitely want to look at their gait analysis and the running analysis. Now, the reason being is this study from Zetoun, published this year, looked at 2020, looked at hip strength and dynamic knee valgus in running, and they found out like your strength markers, your mobility markers doesn't really correlate with the dynamic valgus. Just because you might be weaker doesn't predict your movement. So we should be careful that we don't jump into assessing, predicting movement pattern. If you want to see how they move during running, you have to see them during running. So it's really important. So we should be cautious on taking the strength markers and making an assumption there. Now, how should we approach a runner who comes with hip pain in the clinic? So I try to keep it super simple, because that's the only way I can remember things. So step 1, step 2, step 3. Let's go one by one. Step 1, first, rule out red flags. So we want to make sure that there's no red flags like stress fractures, especially in an older runner. History of cancer, breast cancer, prostate cancer, and all that is really important. Once you're not worried about that, then most likely the pain is due to muscle or tendon issue. So tendon like gluteal tendinopathy, psoas, or a patellar pain, it could be GTPS. If it's a muscle injury, it could be hip flexors, TFL injuries. And if things are not improving in 3 months' time, then I might be looking into more like hip pathology, like hip OA, or hip impingement or dysplasia, because these things can linger on for ages. We should always be cautious of not missing low back pain and referral from the lumbar spine. So that's the thing we always want to make sure that we look into, from referral pattern, especially if they come with the lateral hip pain. So this sort of chart gives you the sort of key points here. First thing is with GTPS history. Do they get pain lying on the side? Are they tender? They must have tenderness around the GT, greater trochanteric region. Obviously, there's a lot of special tests. Single leg stand for more than 30 seconds, derotation test, pain on resisted abduction. Do they get pain on all those sort of provocation tests. And if you want to confirm it, you could use ultrasound or MRI, which are quite good for tendon related problems. With hip OA, it's a bit different. They have a bit more stiffness, difficulty in putting shoes and socks in the morning. They might have associated buttock pain as well. They get pain on provocation tests like the FAR test or the Faber test. They might lose movement, especially extension and internal rotation, and they might also have pain on passive adduction. And the X-ray is more than adequate. And lumbar spine, obviously the history and the classical presentation, they're getting pins and needles, numbness, range of motion, impairments in the low back, positive neurology test, and obviously you might have to look into MRI if you're getting radicular symptoms. A word of caution: symptoms can overlap. So 50 to 60% of patients with GTPS will have back pain, and nearly 30 to 40% of patients with hip OA will also have back pain. So a lot of these conditions coexist. So you could have back pain and GTPS, and hip OA and GTPS. So the key thing is to remember not to really boil down with one diagnosis. A lot of times it overlaps. Another condition which you're more likely to see in a runner than in inactive population is a proximal ITB syndrome. It's got different names: facial lata syndrome, iliac crest syndrome, TFL tendinopathy. So the pain is around the ASIS iliac crest region. They usually don't have GTS tenderness, and this is the ultrasound, which you can see there's a bit of thickening, the endoscopic changes around the ASIS. So this is sort of something which can be misdiagnosed as GTPS, and they can be quite stubborn to treat. I see around few cases a year, and these are my experience. I find they take much longer to recover. They're a bit more stubborn, and it's important to work on lateral stability rather than just the hip. And if all fails, I might put them on a course of shockwave, which you can learn more about in the shockwave module. So it's something to keep in mind. Not all lateral hip is GTPS. Now, if you get a female runner with vague adductor pain, I'm always concerned that it could be bone stress injury. So this is top tip from Professor Ernest Shielder. Vague adductor pain is usually not adductor related. So beware of adductor pain in a female runner. I'm suspicious of stress fractures or a hip joint referral from intra-articular pathology. So if patient comes with adductor pain, especially female runner, and they complain of pain over this region, I want to make sure that they have pain on palpation and pain on positive squeeze test. If that is not the case, then I think it's either a bone stress injury or could be a referral from the hip joint. So take home points here from Lorenzo Maschi, from a top leading sports doctor from UK. Hip groin adductor pain in a female runner, first thing you're going to think of is bone stress. 100% agree with that. So I think adductor longus palpation during the squeeze test, if both are negative, then it's unlikely to be adductor related pathology. Now, adductor related pathology generally happens in people who are rotational sport. If you've got a female runner who is doing 3 days of running, 4 days of running, and playing 2 days of hockey, that's reasonable to expect that. But most runners, if they're not doing other sports, it's not something you see. Now, if your symptoms are taking more than 3 months, and especially if they come with the C sign and other signs, which I'll show that in a second, then you should be suspecting the hip joint, like osteoarthritis, hip impingement, or hip dysplasia. So what are the common signs of intra-articular hip pathology? Things like trochanteric C sign, and also looking into triangulation sign and also deep pointer sign. When you have people coming with this sort of presentation, you need to be thinking that it could be coming from the hip joint itself. So that's really important to be aware of the presentation as well. These are the sort of signs of intra-articular hip pathology, which sort of makes you think that it's more likely to be hip joint. So not all hip pain is from the muscles and tendons, so you need to be aware of that. So when we look into people with hip pain, it's important to think beyond just the hip muscles. So obviously we need to strengthen the glutes, the glute med, glute max, but don't forget the hip flexor. Really important muscle when we talk about, as I mentioned, the first slide, one of the big three. So we don't want to miss those sort of muscles, and also opposite knee. So make sure that we are building up the opposite knee, so kinetic chain, and lastly the making sure they've got good calf, because If you have poor calf, you're more likely to slamp and your hips have to work harder. So this is something you have to check. I'm not saying every patient needs strengthening of quads and calf, but when you have chronic hip pain, you're going to get other deficits. So making sure before they get back to running that we address all those areas. Hip flexors are really strong. I generally try not to do hip flexor training in the initial stages. It irritates the hips. But at a later stage, you really want important. And I'm going to share you some exercise which I do. And quad strengthening of the opposite side is really important. And so some of the simple exercises, with a simple side, plank marches. You can use sliders. See how's the reaction with that. Look into non-weight bearing position, and also looking into improving the recruitment of this sort of key muscles as well. So that's quite important to be aware of. Plank marches, slide marches, and all those sort of active movements. And then you can progress them on into more advanced exercises, such as this is called the advanced psoas march. So they are in this sort of high on a bench, and then using a bands, and then you can go into a step up exercise and then add your high knees as well. So this is quite important to be aware of in this position, how you can progress them. So it doesn't have to be very complex. We're trying to get that same running action when we sort of go into this sort of movements as well. So that's something which you can look into incorporating with your runners at a later stage. Now, nearly all my patients who come to me with hip pathology, especially when chronic, are always concerned. They're a bit worried they might have hip osteoarthritis. They're worried they might have labral tear. So we need to address the psychosocial factors. So generally, things I asked is, from a patient, they want to know, why do I hurt? Is it serious? How long is it going to take? What can we do about it? So I think we need to really address that on session 1. So I always ask my patient, what do you think is going on? How does it affect your life? What concerns you the most? Most of the biggest concern is generally getting arthritis. So that's something which you want to really address. Now, even if you get arthritis, it's not the end of the world. So I'm going to give you an example here. So this is a patient, 46-year-old female with hip OA. She's been treated as GTPS. Symptoms got better, but still ongoing symptoms and stiffness. So she came to me, we took an X-ray, and what you can see from the X-ray is she got moderate to severe OA bilaterally, but her symptoms are only on the right side. Looking at the X-ray, she has more osteophytes and joint space narrowing on the left side. I would have expected the symptoms to be more on the left side, but that's not the case. So that always makes you think like the radiology signs don't always match with the severity. So when she came to me, I gave her advice to sort of reduce. She was running 5 days a week, around 45 minutes. I asked her to reduce to 3 days to around 25 to 30 minutes, not to do it continuously, do it 3 times a week, and every 6 to 8 weeks take 1 week off from running, give her body a break. And I totally stopped all form of incline training because that sort of irritates the hips. And I started on hip rehab, focusing on the 3 key muscle, glute max, glute mid, and at a later stage working on the hip flexors. And the symptoms slowly improved over a period of 3-4 months. And then I gave her advice to monitor her symptoms. If her stiffness is increasing, if she's getting night pain, if she's limping, then she needs to cut down or make some changes or do a lot more cross training. So we try to keep people in control of the situation, like with any chronic condition, so they know exactly what to do and what not to do and how to monitor the symptoms. So as professionals, we need to give patients a green light. Even with arthritis, it doesn't mean like you have to stop everything and just stick with walking. So in most cases, mild to moderate cases, they can still keep running. There's a strong possibility that in few years, 5 years or 10 years, that she will need a hip replacement. But why should she give up on running unnecessarily at this stage? So I think a lot of patients are scared of moving with arthritis. So as long as the symptoms are controlled, they have good education, good strength protocol, then we shouldn't really stop them. So a lot of reassurance, specific advice, clear advice on do's and don'ts. That is not a problem with many patients. Obviously, some patients, they might not be able to do. It's not a guarantee that all patients with arthritis will be able to be running at a good level. But we try the maximum. Obviously, they might reach a point where they have to stop everything. But till then, if they can run for 5 years, 8 years, 10 years, that's still a lot of time which they're going to enjoy. A lot of time it's because of the mental aspect. A common question which we get asked on our courses is, when can we look into imaging? When should we suspect doing imaging? So obviously not everybody who comes in your clinic needs a scan or an MRI or an ultrasound, but if you suspect stress fractures, like a female runner who had a bone health issue, or an elderly male or female runner with previous history of cancer, the international guideline says if you have unexplained hip pain in anyone with a previous history of cancer, that should always be in your back of your mind to make sure it's sent for an MRI to rule out secondary metastasis. And if you're not sure of the diagnosis, then is it from the hip joint, is it from the soft tissue, then possibly that is a good reason. And if they're not responding, you're giving good rehab, they made the modification, and that could be reason you might be incorporating that. And definitely if the symptoms are getting worse, they're not improving, that's a clear case of investigation. And some patients will not engage in rehabilitation unless you get them with a scan. I see that a few times a year. There's no point arguing against them and spending a lot of time. Some people will not be convinced whatever you say. They will not engage in rehabilitation unless they have a scan. They want to see, make sure they're fine. And in those cases, you might need to refer them to appropriate medical professional who can arrange a scan. So that is the role. But generally, most of the patients, it's a clinical diagnosis. And even with somebody with arthritis, sometimes an MRI can be useful, because if you look at this sort of study, it's a small study, but it sort of gives you an idea. So some people, if you look at an X-ray, it can really help you about the severity of their pain levels. So this study looked at patients with pain and without pain with osteoarthritis, and what they found out was patients with more hip pain had bone marrow lesions, especially sort of around the femoral head. So this sort of things makes us to think like it's beyond the sort of active process happening in some patients, and there was quite a bit of significant atrophy, which was sort of also found, which could also lead to that constant cycle of things. So sometimes if you see a patient in a lot of pain and you see an MRI with a lot of bone marrow lesion, that could also give us more evidence to reduce the running load till it recovers, and then you can increase it more. So sometimes MRI is useful even in patients with established osteoarthritis. Obviously, it's not the first line of investigation. So it's knowing when to refer and when to not to refer. And so that sort of gives you sort of the principles which we sort of gone through in dealing with hip. So it's knowing those sort of, although it's less common, in my opinion, they're more challenging while treating than a simple ITB or a simple patellofemoral pain. So when we look into the principles again, there's no harm in recapping it. So step 1, rule out red flags, make sure that we don't miss stress fractures, history of cancer. Number 2, extra-articular, usually linked with training errors, tendon issue, gluteal tendon issue, psoas injury, hip flexors, TFL injury, proximal ITB. And if things are not improving in 3 months, more likely that it's intra-articular, like hip impingement or dysplasia. So that's sort of 3-step process when you're dealing with hip patients. So that concludes my talk. Hopefully that gives you sort of a broad overview on your thought process and clinical reasoning process. So for specific pathologies, refer to the talks on the GTPS and on proximal hamstring tendinopathy. So that concludes my talk on overview of hip injuries in runners. Thank you.